how to manage pulmonary embolism. So essentially, we can do anticoagulation. So I've seen this as a correct answer on some CMS forms. So we can give heparin. Okay, we want to give heparin for this condition. So all patients, unless specific contraindication to anticoagulation, then we can do IV filter. So that's gonna be intravena cava filter. So you can just take a you can I believe you would go through your femoral vein and then go all the way to your that would be your external iliac vein, then go into your IVC and kind of extract that. So anticoagulation, contraindicated or ineffective, low cardiopulmonary reserve. The next thing is going to be thrombolysis. So thrombolysis is really important, especially is with a hypotension, so pressure less than 90, or there's going to be maybe a low bleeding risk. So then we can have also embolectomy. This is going to be percutaneous or surgery. So this is going to be shock or to cause likely to cause death within hours, or there's going to be your failed thrombolysis and thrombolysis contraindicated with persistent hypotension. And then we can see pulmonary embolism management. So classification, if that's going to be your low risk classification. So your low risk classification is going to be no RV dysfunction, and so that we know JVD, no hepatomegaly, no peripheral edema, and there be no hypotension. Typical management, anticoagulation, unless anticoagulation may be contraindicated in that certain patient. If it's submassive, that's going to be RV dilation and or hyperkinesis, so JVD. High risk, elevated, yes, this is really important. I've gotten a UL question twice wrong in this. That can be elevated troponin or elevated BNP. So the way that you're going to remember that is going to be due to ischemia. You're going to get damage to myocytes and you're going to release of troponin BNP. And there's going to be no specific hypotension in that case. There can be also RV dysfunction, hypotension, so systolic blood pressure less than 90. How you want to manage these patients? It's individualized, but we want to do thrombolysis, TPA, and or embolectomy. So acute PE may present with syncope or due to right ventricular dysfunction, cardiac arrhythmias, or vasovagal response to PE. Can also present with mild atelectasis, bloody pleural effusions. It may be difficult to differentiate PE with right ventricular MI, which can also cause right ventricular dysfunction. However, right ventricular MI is less likely to cause dyspnea or syncope, or more likely to cause bradycardia or arrhythmias. So just wanted to come here and recap, guys. You want, for pulmonary embolism, you want to give anticoagulation only if it's not contraindicated. We can go IV filter. So you would go. That's going to be if anticoagulation contraindicated and there's low cardiopulmonary reserve. Then we want to go for thrombolysis. So thrombolysis can be done if there's going to be hypotension, or if we can have any sort of, and there's no risk to bleeding. We can do embolectomy, percutaneous surgery. That's going to be either shock or death within, or failed thrombolysis or thrombolysis contraindicated with persistent hypertension. Low risk people means that they have no right ventricular dysfunction, and or it also means that they don't have any pulmonary artery hypertension. Don't have any low blood pressure. Anticoagulation unless contraindicated. Now, if they start to get right ventricular dysfunction, we can do, and that we're gonna know with elevated BNP, elevated troponin. Then we can do some specific therapy. And if there's gonna be right ventricular right ventricular dysfunction and hypotension, so we can do systemic thrombolysis and embolectomy. Then we can see acute pulmonary embolism may present with syncope due to right ventricular dysfunction, cardiac arrhythmias, vasovagal response to pulmonary embolism, can present mild atelectasis, bloody pleural effusions. It may be difficult to differentiate pulmonary embolism from right ventricular MI, which can also cause RV dysfunction. However, right ventricular MI is less likely to cause syncope or dyspnea, or less likely to cause bradycardia or arrhythmias. So we could get this, but right ventricle doesn't really cause any dyspnea, doesn't cause syncope. Hopefully you found this video useful. Thank you guys for watching, and I hope to see you guys next time.